Hey everyone, we're going to go ahead and get started. Thank you all for joining us. This is workshop 16 in pharmacy updates in CF pharmacotherapy. So if this is not the workshop you thought you were attending, you're free to scoot out now. My name is Kim Novak. I'm an advanced patient care pharmacist at Nationwide Children's Hospital working with the pediatric and adult CF population, and I'm one of your chairs for this session.
Hey guys, I'm Sabrina Sherwood. I'm the other chair for this session. I'm a pharmacist at St. Luke's in Boise, Idaho, and I care for adult and pediatric patients, and I can't wait to hear all of our speakers today, so thanks for coming.
So our objectives for this session are to examine clinical outcomes from real-world CFTR modulator use, to assess medication-related toxicities in the CF population, and to illustrate various models of pharmacy integration within a CF care team. And so we have a variety of speakers here today. What we're going to do is our speakers are going to give our presentations. We'll give about 2 minutes for Q&A, and then as we go through all of our presentations, whatever time we have left at the end, we can have a larger discussion amongst the group. So we're going to start off with implementation of comprehensive pharmacy-driven immunizations in a CF clinic from Justin Moss at Intermountain Health. Then we'll go on to IV tobramycin pharmacodynamic optimization, so kind of our inpatient world with Jasmine Pear at UCSF. We'll look at inhaled tobramycin for Pseudomonas eradication in our kiddos under a year of age with Rebecca Pettit at Riley. We're going to look at concentrations of ETI therapy across the CF population, our interim analysis by Jennifer Gambellet, and then we'll finish up with some ferret models helping to answer some of our questions that we have in clinical care for CF with Yeling Lee at University of Iowa. So as I pull up these slides, we can start with our first presenter.
Welcome, Justin. Yep.
All right, good morning, everyone. So I'm going to be presenting on a group poster that we did with pharmacists in our clinic, Jeff Zobel, as well as a plethora of other pharmacists, as well as our providers in our clinic. This is just an update on the the implementation of the comprehensive pharmacy-driven immunization program in a pediatric cystic fibrosis clinic. It's a lot of words to basically say we gave a ton of immunizations over the last year. And I have nothing to disclose for this presentation. So the background on this is, according to the CFF as well as the International Care Guidelines, people with cystic fibrosis should receive all routine and recommended immunizations, just meaning that they are eligible to take all the immunizations that are recommended and that they should not be missing out on any. And then as of June 2020, all U.S. states, as well as Washington, D.C. and Puerto Rico, allow pharmacists to administer immunizations, though according to individual state laws, which ones can be administered does vary state to state. And then as an integrated pharmacy CF team members, we have many roles and responsibilities. However, managing a comprehensive pharmacy-driven immunization program in CF clinic setting is a novel idea. This was actually brought to us by one of our providers wanting to see about immunizations and just see if there was anything we could do. So this is kind of what drove the idea of what could we do in CF clinic to see what we could do about getting our immunization numbers up within our community, and to see about getting a lot of our patients that maybe don't see their PCP as often as they should, because as a lot of our pediatric patients do, we become their PCP. A lot of the times they see us a lot more than they do their PCP. So in October of 2021, our CF Center implemented a comprehensive pharmacy-driven immunization program so that we could provide all immunizations to our patients with CF in the states serviced by our center, which in our center we have Utah, Idaho, Nevada, Wyoming, and then we have one patient in North Dakota. So we actually have quite a large area of patients that we see. So with this first slide, there is a lot going on in it. As I mentioned, we do have a lot of states. So that first slide showing that we had to gain access to all the different databases for the states, which did take a lot of time. So when we first implemented this program, we actually did not have access to all the states at that time. So we just stuck with what we could, and then we added on the other states with the other patients as we went along. So as part of this care model, once we're able to gain the access, we were able to just kind of look and see where they were at in their immunization program. And then that next part in the process model, you can see there's two lines. They're kind of together, but to kind of make it a little bit clearer, we decided to put it in this way. So basically, that first part where it shows that we would talk to the patient and just go over their immunizations. If they were up to date, we would just ask where they got it, and we would reach out to their providers to be able to update their immunization so that their records would show up to date on everything. And then as part of the model, either myself or Jeff, we would go through their records, and then if they were needing anything at that time, we would go ahead and offer it to them, and a lot of times they would either decline or they would accept. If they were way behind, they may decide to do, let's do a couple of these here, let's do a couple more later, or they would just say, we'll follow up with their PCP. And then at that time, we would get their consent, and then as well as provide their VIS. And then at this time, I would process the immunizations to their insurance using Enterprise through our the outpatient pharmacy. And we set this program up with the pharmacy supervisor in the outpatient pharmacy to say this is what we're going to do, and she helped this process. So we would run things through. The nice thing with pediatrics is if they are on Medicaid or just don't have insurance at all, we are able to run the medications through the program for the now it's escaping my mind, but it's the children's, the VFC, the vaccinations for children, sorry. And we would able to just run it through them. So even if they didn't have insurance or if they had Medicaid where Medicaid does not pay for it through a pharmacy, we still had options to be able to get our patients the vaccines they needed. So at that time, we would process it. We would get the supplies as well as the vaccines. And then at that time, Jeff, because I refuse to give vaccines, not because I don't believe them, just because I'm gonna faint if I see a needle touch skin. Don't let the tattoos fool you. When it comes to syringes, I can't do it. So at that time, Jeff, the nice thing with our workflow is we see the patient early, right after the MA sees it. So by the time everyone else sees them, we are already ready to go into the patient room to give the vaccine. So this actually does not cut down on any type of workflow or really cause any additional time in our workflow. It adds a few minutes to sign the form, and depending on the patient, Jeff can go in and give the vaccines sometimes within a minute or two. So then at that time, we're able to give the vaccine, and then we'll update their database, and then the patients will receive their new immunization records at that time. So the purpose of this is to show the implementation of the pharmacy team can have an impact on the immunizations with our patients with CF. The methods that we used was a retrospective quality improvement analysis from October 1st, 21 to September 30th, 2022. So we actually just finished this about a month ago. We had an IRB approved by Intermountain Healthcare, and then the primary outcome measures was to look at the percentage of our population with CF who received the following immunizations pre-post of the implementation of this pharmacy-driven program. So the three that we really wanted to look at was the PPSV23, HPV, as well as the MCV, or for meningitis. So those were our three big ones, because we noticed that in our population, those were the numbers that were the lowest. So those were the ones that we really wanted to hit when we started this program. And then our secondary outcomes, we wanted to look at all the immunizations that we provided and just kind of show how many we did, because we figured, well, if we're going to offer all of these, at least let's keep track of it. But our main focus was those 3. And then we used the Mann-Whitney tests. So as you can see, as our result, when we started this, 58 of our 218 eligible patients that could receive the Pneumovax 23 had it. This was either due to PCPs who knew about CF and knew that with CF patients, anyone over the age of 2 was eligible, or anyone with any type of asthma and respiratory should get it over 2, not just 65 and over. And a lot of these also we were given inpatient through our pre, but as post, you can see that we hit 217 of our 218 eligible patients. And as of about 2 weeks ago, we actually hit our 218 out of 218. So right now, our clinic is 100% vaccinated with the Pneumovax that is eligible. And then with HPV, this is 32 of 74 patients that were eligible had it. This is for their complete series, not just who haven't had it at all. So the number that we're at, that 90%, was either complete series or to complete their series. And as a lot of people probably know, the HPV one can be a little tricky with patients, so we don't think that number is going to go much higher, except for when patients become eligible, because we've pretty much talked to everybody at this point. And then on the last one for the meningitis, you can see we had, sorry, it's so hard to read, the 8 of 34 pre, and now we're at almost 100% as well on that one. So on this next slide, this is kind of the reason why we wanted to, for our post, we wanted to show how many we actually gave. So as you can see, we did a lot of the Pneumovax, but because we had access to the COVID vaccine as well, we were able to give several of those. So this did take a lot of coordination, and especially with all the new guidelines and updates and different formulations. But you can see that behind that, COVID was a very large one. And then from there, those the other 2 main ones that we wanted to hit with HPV and the meningitis were our next 2 largest. And then after that, we did offer flu to either catch our younger population up when they need 2 doses, or if they just weren't eligible otherwise. And then we did the various other ones. So our total immunizations for this project was 523. But as of last week, we were up to almost 600. So in conclusion, the international ends, the CF guidelines recommend that all routine and recommended immunizations CF patients should receive, and that an integrated CF pharmacy team of dedicated, the pharmacy and the pharmacy technicians can serve many roles just outside of just the normal CF care team. And that we're able to administer immunizations, and that a pharmacy-driven immunization care process model is a new role in CF, but as you can see, integrated properly can actually have really good outcomes. Thank you.
All right, well, while we're looking through the question and answer app, does anybody have a question? Well, I'll ask the first one. I thought that was an amazing presentation, so great job, Justin.
Thanks.
I wanted to get your opinion on if you think this had any impact on your relationship with patients. Like, do you think that they saw the benefit with this, and if so, how?
I think we have a pretty good relationship, and I don't think it's just like our team, but I want to probably say a lot of the pharmacists in this room and pharmacy technicians probably already have a really good relationship. Especially those who are helping with insurance problems and adherence and trying to make sure that people have medication. So I feel kind of on the front line that at least in our clinic, I think we're one of the disciplinary teams that most patients want to see no matter what. Even if they're only there to just do PFTs, if there's a question, they'll always come to us. So I think that also helps in trying to drive this process, just for the fact that they do trust us and that we already have a good, really working relationship with them.
Great, thank you.
Since you have so many patients across different states, did you encounter any challenges getting access to the different state programs if you weren't licensed in that particular state?
Yeah, I'll let Jeff answer that one, just.
So Intermountain at least helps a provider in Idaho, and so that would be, right, if we already have a network there that calls all those states. Nevada and go, this is regulatory work. Wyoming was the hardest, I don't know, Wyoming was very difficult to get into. You had to actually go through a contract, the hospital had to sign a contract with the state, and so that took the longest. So some of these has some regulatory, but since we're getting them in Utah, we're able to give them in the state, but then I have to document in the state databases, except for Wyoming, will not let anything outside the state documents. So we have them do a bit of form, and they have to go to some provider in Wyoming to document. But the other ones can document, Idaho and Nevada can document in there as historic.
Oh, yes.
There was a few times if there was some patients that were admitted and they were behind on vaccines, we would try to get them while they were inpatient. But since we round with the inpatient team once a week, it wasn't too difficult. I think the hardest part about that was actually talking to the inpatient team and just making sure that they were given, because there were a few times where patients weren't given, because if they're inpatient, we're unable to give them, they have to be done through the inpatient. But if for some reason they weren't, we would just track it and then we would talk to them and get it set up for when we'd see them actually in clinic again. As far as the adult center side goes, you'd have to talk to Dave Young. It's just because we're different systems. So since ours is Intermountain and theirs is the U of U Health, it is a little bit different system, and so it works a little differently as far as that. But Dave would have to speak more on that as far as the adult side, since it's not the same health program.
So when I first started at the Adult Center 26 years ago, I came in and noticed that they're doing a pretty good job of food. They're doing a horrible job of pneumococcal. And I asked, how come you guys aren't recommending pneumococcal? Think about it. So we did a project, we went from 10% vaccination rate to 90% or something like that in 6 months. And all we did that, right? And then we expanded that into all vaccines. So we screened for all vaccines in our adult clinic. And prior to this program, our community transition people were woefully behind on multiple vaccines, and so we were playing catch up for decades. And now, for this program implemented, they're actually going to come transition to us in fully vaccinated. So Jeff and I got talking about a project that would be useful for public health and for our center in total, and that's going to pay off long term. Plus, the other piece of this that is not on the presentation, but their vaccines are financially, it's a high money income thing for an institution. So one of the things that there's a potential here is you could potentially justify more pharmacy services because this is something that could money for an institution, and you can monetize that, which Jeff is working on.
Yeah, we submitted this for publication, pediatric pulmonology, and where it's at the process. But we got about $45,000, so 0.3 FTE. So it's just services.
Yes.
I think we have time for one more question. Go ahead. Yeah.
So in our center, we're sort of seeing from the pandemic, some vaccine fatigue. And even though when we look back, our influenza rate, in the past has been terrific, we've noticed now things are just like, and so I'm wondering, did you have any of that experience, number one? And number two, did you have any tricks of the trade you can give us to sort of, because we all have really good relationships, but patients are kind of just saying no thank you.
Yeah, and I mean, we did see a lot of that as well, where exactly what you're saying is they're tired of hearing about the COVID-19 vaccine, and then because of that, they're tired of hearing about all vaccines. And even if it's something that's recommended, we did have a lot of parents that would just say, no, thank you. That's, and then we would just try to educate them, but we never tried to push it on them and just say, here's the literature on it. This is why we're recommending it. A lot of times we would provide them with the VIS just so they would have that to look at. And then we would just talk to them every time we would see them in clinic, unless they just said, please don't talk to me about this again. I don't want it. And there was a few times that did happen. But for the majority, especially with the PPSV 23, usually we were able to get that pretty easily, but a lot of the other ones, especially with HPV and some of the others, there was a lot that just said, no, thank you. But a lot of it's just talking to them, educating them, and just letting them decide on their own and not really just push it. Yeah, so when we go to bill for it, we bill it to the insurance, but we also put in there for like an administration fee, so that does go into the outpatients as well as far as part of the revenue. Yeah. Yeah, we can't report it though. Yeah.
So we got the average prices. But if you can, there's probably more information. We did the internal one and the second.
Okay. All right. Thank you, guys.
Great. Thank you,
Thank you.
Justin. All right, now we'll welcome Jasmine to the stage.
Hi, everyone. I'm delighted to be here today on behalf of our team at Children's Hospital of Orange County to share with you our research titled Tobramycin Pharmacodynamic Optimization and Impact on Exposure and Nephrotoxicity in Children and Young Adults with Cystic Fibrosis. So for this presentation, there are no relationships to disclose. And to start, I wanted to show an example of a representative case of daily exposure with dosing projections. So here we have a 14-year-old male who started tobramycin empirically at 10 milligrams per kilo every 24 hours. We drew 2 levels to calculate patient-specific PK, as shown on the left-hand side here. And the table to the right is an illustration of the limitation of peak and trough monitoring alone, and not taking into account the overall drug exposure. So what you see here is our patient with his starting regimen in column A at 10 milligrams per kilo per dose, and he weighs 50 kilos. We calculated a Cmax and got 30, an extrapolated trough of 0.01 or undetectable, time of undetectable levels or the drug-free interval to be 11.5 hours, a half-life of 2 hours, and a VD of 0.31. And of note, the limit of detection for our lab was 0.5, so our time of undetectable levels is tobramycin when it falls under 0.5. And to follow the example of the 3 dosing projections for the purpose of comparison, we first turn to regimen B. So if we were to go up on the dose to, say, 13 milligrams per kilo per day, and we keep the frequency the same, you see a corresponding increase in Cmax to 40, which is our peak, so since it's reflective of dose, and AUC also increases to 128, and the extrapolated trough remains undetectable. But for column C, when you keep the same dose of 10 milligrams per kilo and shorten the frequency to every 18 hours, you're basically giving a patient a dose 6 hours sooner, and you see a peak that is essentially unchanged because the dose doesn't change, but since you redose the patient sooner, the overall daily AUC will increase, and the extrapolated trough remains undetectable, but the drug-free interval is shortened by 6 hours. And the last regimen to evaluate is column D, where you give the same dose of 10 milligrams per kilo, but give it every 12 hours. You see no change in the peak, as well as no change with the dose. So essentially, since you're giving it every 12 hours, you're doubling the daily exposure, or AUC, with more frequent dosing. And remembering that AUC is just determined by the dose divided by clearance. So if we expect no changes in clearance, as you increase the dose, you increase the AUC. And in this regimen, our extrapolated trough is now 0.6. So generally, people target a peak of 20 to 40 and a trough of less than 1. So the key point I was hoping to make with this slide is that in all 4 regimens, if we were only monitoring peak and trough, each of these regimens would meet the general monitoring goals for tobramycin. And what we are seeing is that a change in frequency leads to an increase in AUC. So as we move forward with the presentation, I'll discuss the data from our institution looking at patients' overall drug exposure and risk for nephrotoxicity with the different proposed monitoring protocols. So the objectives for our presentation today are to evaluate the difference between 2 different tobramycin monitoring protocols in patients admitted with a cystic fibrosis exacerbation, focusing in on daily exposure defined by the AUC-24, target peaks defined by Cmax, the rates of nephrotoxicity, as well as improvement in FEV1. So this study was done at Children's Hospital of Orange County. It's a 334-bed academic tertiary care medical center located in Orange, California. And we are a cystic fibrosis care center recognized by the CF Foundation with about 80 to 90 patients in our CF registry. So as we know, cystic fibrosis is a progressive disease caused by dysfunctional CFTR protein. And primary disease manifestations include persistent pulmonary infections as well as acute exacerbations. So antibiotic choices for treatment of an acute exacerbation are typically directed at the most common pathogen identified in CF airway cultures, being Pseudomonas aeruginosa. So, aminoglycosides are commonly used in the management of CF exacerbations, and the most common one in pediatric CF centers being tobramycin. And it is an anti-pseudomonal agent that exerts concentration-dependent activity with a Cmax, or peak, to MIC ratio of 8 to 10, best predicting efficacy. So extended interval dosing is used to optimize the bactericidal effects while minimizing toxicity by targeting a higher peak, optimizing Cmax to MIC ratios, and enhancing post-antibiotic effects. So it's been shown to lower incidence of adaptive resistance as well as improve overall outcomes for patients compared to the multiple daily dosing regimens, with lower accumulation in renal tubule cells and risk for nephrotoxicity, improved penetration into the pulmonary epithelial lining fluid, and less frequent administration. And in our CF patients, they often receive multiple courses of tobramycin over their lifetime and are at risk for drug-induced toxicity. So careful tobramycin monitoring is to optimize efficacy and minimize adverse drug effects are of particular importance. And with toxicity being correlated with high trough levels and overall drug exposure, developing adequate monitoring protocols is going to be essential. The current CF guidelines do recommend extended interval dosing over traditional multiple daily dosing. However, there is no consensus on recommended monitoring goals. So at CHOC, our tobramycin TDM protocol from 2013 to 2017 monitored or targeted a Cmax of 20 to 40 and a drug-free interval of 2 to 6 hours. And for the purpose of this presentation, I'll call this the pre-protocol group. In 2018, the protocol was changed to now target a Cmax of 20 to 40 and an AUC between 50 and 200. And I'll call this group the protocol group. So just to highlight the changes, Cmax was kept the same, and we replaced the goal drug-free interval with a goal AUC of 50 to 200. We hypothesized that patients who were receiving therapeutic drug monitoring in the pre-protocol group experienced higher daily exposure and nephrotoxicity compared to the patients that would be monitored using the protocol group analysis without changing any effects in FEV1. So for our methods, it was a retrospective chart review of patients who were admitted to CHOC between March 1st, 2013 and June 30th, 2021. We included patients who were 21 years and younger, admitted for a CF exacerbation, who were receiving IV tobramycin with at least 2 levels reported. Our primary endpoints were to look at drug exposure defined by an AUC 24, peak defined as Cmax, and nephrotoxicity as defined by the pediatric rifle criteria, as seen on the slide here. Our secondary endpoints looked at the change in FEV1, 10% or greater, from admission to the end of therapy. For our analysis, we did use the student t-test to analyze our continuous data and the chi-square test to analyze our categorical data. So to get to the interesting part, our results. First, starting off with our demographics, we didn't see any significant differences between the pre-protocol group and the protocol group for our demographics, looking at age, gender, weight, length of stay, baseline serum creatinine, and the use of concurrent nephrotoxins. So both groups were adequately balanced. And this next slide here, it depicts the concurrent anti-pseudomonal agents that were used during our patients' admission. So all patients did receive dual anti-pseudomonal therapy, combining tobramycin with typically a beta-lactam, most commonly piperacillin tazobactam. And the antibiotic choice was really driven by previous history as well as susceptibilities. So looking at tobramycin daily exposure between the two groups, we saw a significant difference between the pre-protocol group with an AUC of 164 and our protocol group with an AUC of 99. When we looked at daily dose and dosing frequencies, if you look at the graph A on the far left, you can see the difference in total daily dose between the two groups, and it's significantly higher in our pre-protocol group compared to the protocol group. In the middle box, or box B, you can see the driving forces. So our pre-protocol group regimens were adjusted to multiple daily dosing, with about 70% of the patients receiving more than one dose in a 24-hour period. Lastly, in box C, looking at the time of undetectable levels, or the drug-free intervals, we see a significant difference between the two groups, as the pre-protocol group received more doses per day than the post-protocol group. Here's the data in regards to Cmax, and as expected, there was no significant difference as the goal Cmax did not differ between the two protocols. And then to look at nephrotoxicity, so in the chart on the right, what you are seeing is the proportion of patients experiencing AKI. We saw a significantly higher proportion of patients in our pre-protocol group experiencing AKI defined by the PEDS rifle criteria for both risk and injury. About 10 patients in the pre-protocol group experienced risk or injury versus only 2 in our protocol group. And the odds ratio for nephrotoxicity in patients that received monitoring based on the protocol adjusted for time of undetectable levels of 2 to 6 hours was 5 times higher than those who are monitored for AUC. With further logistic regression analysis, we identified that a daily AUC of greater than 150 was a significant risk factor for nephrotoxicity. And finally, looking at our clinical outcomes, or FEV1, there was no difference in the rate of attainment of a change in FEV1 10% or greater from admission to the end of therapy. Though notice here the numbers are decreased and only 70 to 80% of our patients were included, as not all patients were eligible for pulmonary function tests. So in summary, targeting a time of undetectable levels of 2 to 6 hours did result in increased daily exposure and risk for nephrotoxicity. Our extended interval dosing and AUC monitoring protocol resulted in decreased daily exposure with lower risk for nephrotoxicity, while still achieving similar Cmax and clinical outcomes. Some limitations to the study included that it was a retrospective chart review, single center with small sample size. However, it was powered to detect a hypothesized difference in AUC. There is also no absolute thresholds for FEV1 that are needed to meet for a pulmonary exacerbation. Rather, it's based on clinical status. And it did not assess clinical resolution of infection, rates of recurring infection, and returning patients. So in terms of clinical significance for our study, we saw that tobramycin monitoring with optimized peak and daily exposure targets rather than time of undetectable levels resulted in similar Cmax with significantly lower drug exposure and risk for nephrotoxicity. Return of lung function reflected in the changes in FEV1 was similar between the two groups. So in conclusion, we saw that peak and trough monitoring alone is inadequate. And then just a special thanks to one of our biostatisticians, Dr. Lois Sayers, who had helped with our data analysis. References, and I am happy to help answer any questions that you may have.
Thank you very much. We have several questions here in the queue. We'll start with this one first. It's kind of a two-point question. First, does your micro lab report out your Pseudomonas tobramycin MICs? And if so, like, how did that play in a role into your protocol or how you would customize your dosing? And then how did you come up with an AUC goal of 50 to 200?
Yes. So first, the lab does report out MICs. And when we looked at MICs, our tobramycin MICs for the Pseudomonas they were all susceptible. And there was actually an earlier study done at CHOC looking at, with prolonged time of undetectable levels, would there be an increase in resistance? And in that study, they saw no change in resistance. And so they felt comfortable with the longer time of undetectable levels past 2 to 6 hours that had helped drive this change to AUC monitoring. And the goal AUC of 50 to 200, while that's a very large range, there's really no consensus on a goal target. Previous literature has reported that 75 to 125 would be a good range. However, there is no consensus on what the ideal or optimal AUC monitoring is.
Thank you. You answered a few questions in that, so great job. Another question for you. How did this change the clinical practice at your institution?
Yes, so I can say what had happened at CHOC. What our current protocol now is to aim for an AUC of 50 to 150. Since we were seeing that increased risk for nephrotoxicity with an AUC of greater than 150, we decreased our goal to 50 to 150, and our Cmax goal remained at 20 to 40.
Awesome. Okay, time for one more question, and I have another one in here, and then please feel free to keep sending in your questions, and we'll get to them at the end. When do you collect levels? Like 2 hours, 8 hours?
Yes, so we typically collect levels on day 3 of admission, and we'll do a 2-hour level as well as an 8 to 10-hour level. However, we recommend a 2 and 8 hour level with most patients.
Great. Thank you so much.
Thank you.
All right. Next, we have Rebecca Pettit.
All right. Good morning, everybody, and thank you to the moderators for having me today. Today, I'm going to talk about a project we did regarding the safety of inhaled tobramycin for Pseudomonas aeruginosa eradication in CF patients less than 1 year of age. I have nothing to disclose with regards to this presentation. So as we all know, in CF patients, they have thick, sticky mucus in the lungs that can become infected with bacteria such as Pseudomonas. We have the CF Foundation guidelines that recommend that if we culture that Pseudomonas in the airways, regardless of if they're sick or not, we should try to eradicate it. And the recommended treatment is inhaled tobramycin, 300 milligrams, twice a day for 28 days. We know that early eradication has the potential to delay progression to chronic infection. However, there is limited literature about the safety and efficacy of inhaled tobramycin in our youngest patients, so those patients less than 1 year of age. When we look at what literature is currently out there, there are a few studies that give us some clue into the safety. The first one, Choi and colleagues, was a retrospective chart review that included 18 patients. They did look at early eradication for Pseudomonas in patients less than 1 year of age. They included patients from early to 1 year, but in the less than 6 month patients, they used a dose of tobramycin of 80 milligrams twice a day instead of the 300 milligrams twice a day. They did find 3 patients in their study, or 10%, that had cough associated with the inhaled tobramycin. The next study is the optimized study. So this was a double-blind randomized controlled trial. And if you remember, they were looking at the addition of azithromycin versus placebo to inhaled tobramycin for the treatment of Pseudomonas. They did include patients as young as 6 months, and there were 80 patients in this study between 6 months to 3 years of age. When they looked at adverse effects, they just looked at azithromycin versus placebo, and you can see there were adverse effects in each group there. The next trial, the ELITE trial, was an open-label randomized study in patients down to 6 months of age. They compared 28 versus 56 days of inhaled tobramycin. They included in the study 37 patients that were in our younger age group, but that younger age group was 6 months to 6 years of age. And they had overall reported adverse drug events in 58 to 73% of patients in that total study, with cough being the most common. So as you can see, we have a little bit of data in that youngest age group, but not a whole lot, and some not very clear. So the objective of our study was to compare the incidence of adverse drug reactions in infants less than 1 year of age to children 1 to 18 years of age receiving inhaled tobramycin 300 milligrams twice a day for eradication treatment of Pseudomonas aeruginosa. It was a retrospective analysis. We collected data from patients that were 14 days old to 18 years that were followed at our center at Riley Hospital for Children in Indianapolis. We looked at patients as far back as 2008 to July of 2021, and we matched patients in the 2 different age groups based on CFTR genotype and a 1-to-3 ratio. We included patients in our age demographic that were diagnosed with CF who were using prescribed inhaled tobramycin for Pseudomonas eradication. They had to be culture positive for Pseudomonas, either via throat swab, BAL, or sputum culture. And we wanted them to not have had a previous Pseudomonas positive culture within the previous 12 months. They had to at least receive 1 dose of inhaled tobramycin 300 milligrams twice a day, and that had to be initiated in less than 28 days from that first culture. We excluded patients that received other IV or inhaled anti-pseudomonal antibiotics prior to treatment completion or in the previous 6 months prior to eradication attempt. As far as how we define adverse events related to treatment, we included patients that had at least one of the following. So for respiratory symptoms, that included bronchospasm, increased cough, upper respiratory tract infection, vocal changes, or allergic reaction, or others that were reported. This had to occur during the inhaled tobramycin treatment. We also looked at ototoxicity. For this, we looked at tinnitus, as well as documentation of hearing impairment. And this could be documented during the treatment period or the next 5 years post-treatment. Discontinuation, we looked at discontinuation due to intolerable side effects during treatment. We also looked at the incidence of multi-drug resistant Pseudomonas, and you can see the definition there, as well as the presence of any mucoid strains. We define treatment success as being culture negative for Pseudomonas within 3 months after treatment. Treatment failure was being having a positive Pseudomonas culture within those next 3 months, and we define Pseudomonas colonization as greater than 2 cultures for the next 6 months with at least 1 month in between those 2 cultures. So we started out with 179 patients, and we were able to include 12 patients in the infant group, and then those were matched to 36 patients in the children group. So when we look at baseline characteristics, you can see they're obviously different in the age of the patients, similar in gender, and then weight is obviously different given our 2 age groups. You can see we matched on CF genotype, and so those are similar between the 2 groups. When we look at concomitant medications, we see that there were more patients on CFTR modulators in our children's group, which makes sense given the time period we're looking at and what ages modulators were approved for. We did also collect those that were on concomitant PO azithromycin, and we found no difference between the 2 groups. Sometimes at our center, we will also put patients on PO Cipro if they have symptoms at time of Pseudomonas culture, but you can see there's no difference in that between the 2 groups. As far as adverse drug events, we did find that more patients in the infant group did have an adverse drug event. However, when we looked at what was really driving this increase, it was cough, which is something we kind of expect for patients on inhaled tobramycin, and also what we kind of expect for patients that have a Pseudomonas infection. So when we removed cough, we found that there was no difference between the 2 groups. None of the patients actually had to stop inhaled tobramycin therapy due to the adverse drug events. You can see as far as the other adverse drug events, besides just cough, we had 1 patient in each group have a decrease in hearing and 1 with epistaxis in the infant group. When we looked at those that continued to be culture negative, we saw no difference between the groups in the initial period. However, we did find that more patients in the children's group as opposed to the infant group maintained being culture negative at the 18-month time period. As far as treatment failure, we found similar rates of treatment failure in the between the two groups, as well as those that went on to be colonized with Pseudomonas. As far as multi-drug resistant Pseudomonas, we didn't find any in the infant group, as you might expect, given their age and exposure to different antibiotics. We did find some in the children's group. We also looked at days to next oral antibiotics and didn't find a difference there. Days to next hospitalization, there were only 5 patients in the infant group and 12 patients in the children's group that went on to be hospitalized during the time period, and we found no significant difference there. So the most common adverse drug event that we found in both groups was cough. It was significantly higher in the infant group, but no patient required cessation of therapy due to the cough. When cough was removed, we didn't find any difference between the two groups. One patient in the infant group that did have the epistaxis, we did have to back down to once-a-day treatment for a period of time given that issue, but they required no further intervention after that. We did find that fewer patients in the infant group maintained persistent negative cultures at 18 months. As far as limitations, it is retrospective, so we were limited by what adverse drug events were reported by caregivers. So it's difficult to tell if parents of the infants were more in tune to report those side effects versus the older children. There's no way to really flesh that out in a retrospective study. And it was a small sample size. However, given the age group, it was pretty high number of patients for that. So in conclusion, we found that the infant group did have a higher rate of adverse drug events, but it was mainly driven by cough. So really, we feel like this data shows a low risk of adverse drug events outside of cough, indicating that the use of the inhaled tobramycin at the dose of 300 milligrams twice a day may be safely used in this age group. I would like to acknowledge my pharmacy resident that completed this project, Daniel Rigsby. And at this time, I will open up for any questions.
Thank you, Rebecca, for that extra information on our youngest patients. One question I had for you was that with the increased incidence of cough, is it standard at your institution to always use albuterol to start their chest physiotherapy session, even in those younger children?
That's a great question. And to be honest, our practice in this young age group is variable. A lot of times we'll just use albuterol PRN. And a lot of times in the less than 1 year of age, we're not doing that standard treatment. So we don't standardly recommend that patients do albuterol before the inhaled tobramycin, but it's something that may be beneficial for patients given that high incidence of cough.
Thank you. Another question we got in the Q&A. Did you consider adding renal dysfunction or detectable troughs in your ADRs?
Yeah, so we did consider that. However, our patients don't really get labs on the outpatient side that frequently. And so it really didn't prove any value because we weren't getting labs around that time, and that we don't routinely check troughs on a otherwise healthy infant who's just doing Pseudomonas eradication inhaled outpatient.
Does anyone in the audience have a question? I haven't. Oh, go ahead.
Thinking about, for instance, having do you think at all about maybe how technique of the inhaled tobramycin is going to require? I know a lot of our parents say put it on with the kids.
Yeah, so the question was about technique in our youngest patients. I think that definitely is a consideration. And I think also, depending on when the patient was positive, some of those patients we had initiated some nebulizer treatments and actually taught them in clinic how to use the nebulizer, how to clean things like that. But some of these patients, we hadn't actually done that yet when their culture was positive, so we had to do that education over the phone, which is probably not as ideal as the in-person education. But yes, it is sometimes a difficult age group to make sure technique is adequate, so that's definitely something that could have played into that. Yeah, I think there is some like she brought up what the care guidelines recommend. I think we're seeing some variability in this new area of modulators and things about when we're introducing, and sometimes even patients are culture positive before that is started, even in that younger age group in those first few months. So we are seeing some of that as well. Yeah. Yes. Yeah, it was about a 4 to 6 month old from my memory of who had the epistaxis.
Okay, and one last question in the Q&A. Was hearing loss confirmed objectively, or was that based on parent report?
Yeah, so the hearing loss that was reported was based on parent report. It was not objective. And that patient also had a significant history of ear infections. So that remains to be seen if that was kind of less likely drug-related, more, ear infection related.
Can I ask you just one more?
Yeah.
Okay. Another one came through. What dose of Toby was given?
300 milligrams twice a day.
Twice a day. Okay.
For everybody.
Perfect. Okay. All right. Thank you.
Thank you.
And now we'll have Jennifer come up.
All right, so thank you guys for coming today, and thank you so much for organizing the workshop. I'm so pleased to be here today. So I don't have disclosures specifically, but I do have grant support related to this presentation. So I wanted to start by introducing sort of the underlying purpose and rationale for the study is really looking at or thinking about precision medicine. And so I wanted to give a little bit of background so that we're all on the same page as we go through our presentation today. So precision medicine is really understanding the unique differences between each patient to match that right medicine at the right dose to the right person. So it's a little bit different than a lot of the studies that we look at on more population level and taking it down to the specific patient that's in front of you in the clinic. And so to illustrate this point, you can see on the left side of the screen your population where people have a lot of similarities and and are very similar to each other. But there are individuals that have specific characteristics that are different and set them apart. And armed with additional information such as genetic data, so of course your CFTR genotype, maybe pharmacogenomics information, and biospecimen data such as plasma concentrations of drugs, and other times other unique data as well, then you can link to a specific dose for each patient. So obviously, most people are going to respond very robustly to the normal dose, but some people respond better or at least as robustly with a lower dose. Some need a higher dose. And of course, others respond to an alternative medication. And this is true for most drugs. As you guys know, I'm not probably the only non-pharmacist in the room.
for modulators, we don't really do that very much right now. We primarily focus on the CFTR modulator or CFTR genotype to determine the modulator, but we don't do a lot of this other stuff, or at least we don't have a lot of data for doing it as yet. And so taking a step back for how drug concentrations influence response, just to remember that when you start a new drug, you take a new dose, you have nothing in the blood, the drug gets absorbed, you raise your concentrations, your body starts to kick in and clear that drug, distribute it to the tissues, your plasma concentration falls, and you take another dose at the end of the dosing interval, and you continue this process until you reach a steady state. And everybody reaches a steady state at a different level. And so, of course, if you have the lower steady state for whatever reason, once your body has sort of matched your body's ability to absorb the medicine, if you're at that lowest level, you are at risk for suboptimal response or treatment failure. And then you really want to be sort of in that middle range where you have the effective drug concentration with minimal side effects. In some cases, for many drugs, we can be too high where you have adverse events. For modulators, we're not 100% sure does a too high concentration really happen where we have these adverse events, because in the clinical trials there are very few adverse events that were identified, very few discontinuations in all the clinical trials across most age groups that were potentially concentration dependent. But as I'm going to show you in our study designed for check PK, which I'll get to in just a second, that may be something that we need to start thinking about. So check PK is a sub-study of check SC, which is characterizing CFTR modulated changes in sweat chloride. And the full details can be found in poster 43. But the purpose of the main study, which has so far enrolled around 5,000 patients since 2018, is to evaluate changes in sweat chloride after modulator treatment, assess the variability in sweat chloride responses, and determine associations with long-term CF disease outcomes, and also identify potential covariates that may influence response. Check PK, on the other hand, is a sub-study of that, and re-enrolled participants at 6 sites. And it's the first attempt to assess sparse sampling of blood samples to assess the variability during typical real-world use of triple combination therapy. And so we were really able to leverage this existing infrastructure of the check SC study at these 6 sites to add on additional data and biospecimen collection, which you can see here, where after patients were assumed to be at steady state after a minimum of 2 weeks of use, we had them come in for a visit. They had sweat chloride collection, plasma collection at 0 and 4 hours. And 4 hours was selected because it's kind of in the middle of those peak concentrations for all 3 of the modulator compounds. We collected demographic and clinical characteristics, and also in the future, CFTR linkage data will become available, so we'll have additional data in the future. The samples were quantified as in a simultaneous multiplex mass spec assay in a CLIA and GLP certified laboratory, and an assay validated at FDA standards, which I just found out was accepted for publication yesterday. So starting with our concentration data results. So this is really our initial concentration data, raw data, 0 and 4 hours that you can see here for elexacaftor, tezacaftor, and ivacaftor. And so during drug development, the manufacturer really does conduct dose-finding studies to maximize the number of people who achieve the maximal clinical effect. As I mentioned, very few adverse effects were found, so the tendency was to push the concentration as high as possible to make sure that most people would get the maximal benefit. And so in this case, as I said, a few side effects were identified. And in the concentration modeling that's conducted, there is an upper target that you want to get, that above which there is a plateau for clinical response. So if you drive the concentration higher above that level, you're unlikely to get additional clinical benefit because there's a ceiling effect. And if you're in between the upper and lower limits, you're probably going to get some clinical response. It may not be the maximal response, but you're probably going to get it. And then if you're below the lower limit, the clinical response is a bit unlikely. So as you can see here, I've marked the upper and lower limits that are defined by those dose-finding studies, and I've also arbitrarily defined 2 times the upper limit of upper limit of those values, just so you can kind of get a sense of where people fall. So obviously at 0 hours before they've taken the drug, you can see quite a few people fall above the upper limit, but by the time you get to 4 hours, almost everybody is well above that upper limit, which suggests that the dose-finding studies were very adequate. Okay. However, those targets for all these drugs are not based on 0 hour or 4 hour concentrations. They're actually based on the C average. And they're actually based on the average concentration of the dosing interval. And so here we've done the simplest analysis, and I have other studies where we've done more intensive sampling over the dosing interval in order to do more comprehensive non-compartmental analysis to get a better sense of all the pharmacokinetic parameters. And so what we've done here is we've assumed a linear relationship between the 0-hour concentration and average concentration, which is something that's supported by my other data. That shows a very close correlation that's nearing 1, a correlation coefficient of 1. So they're really tightly, they seem to be pretty tightly associated. And this doesn't take into account other covariates. We are planning population PK analysis in the future so we can better estimate, but I thought it was useful to show this today so that we could kind of get a better sense of that average concentration over the dosing interval. And you can see those same targets that I mentioned here, the upper and lower, where you can see that basically nobody is at risk for treatment failure, which is great. But what is a little bit more interesting is the number of people that are really a lot higher above that upper target. So they're having these very high concentrations above which they can't really expect any additional clinical benefit. So, is that useful to do? So the next thing is to think about the clinical implications of these findings and whether this affects our clinical outcomes. And of course, this is the CHECK-SC study, so it's based on sweat chloride, and so that's what I have to show you today. And so we look at the sweat chloride, which is essentially steady state sweat chloride level that's at the time of the visit. And it is correlated with the concentration for all 3 compounds, as you can see. We do have a weak correlation that is statistically significant when including all concentration ranges. So that means, from the lowest concentration all the way to the highest. As I mentioned, I just showed you that many of these data points are actually above that upper limit, above which there's a flat relationship. There's no more linear relationship up there. So this is probably not completely accurate since it's not linear above that point. Because you've already maxed out the maximal clinical response. And so what I did here is I pulled out all the values above that upper target for each compound, and I took them out, and I just looked at the part that should be linearly related based on the dose finding studies. And I reanalyzed them. And of course, this reduced the sample size a lot because we had quite a few people who were extremely high concentrations. And so we still see an overall linear association between the 2 variables and a strengthening of the correlation coefficient, which is really what we expect to see in this concentration range. And so we do see that there's evidence to support relationship between the concentration achieved at steady state and the clinical outcome we can expect. So what does this mean? It really does mean that concentrations below that upper target may be at risk for suboptimal clinical outcomes. It means that when providers may reduce dosing to manage side effects without knowing where their starting point is, they may be entering a range of concentrations that may significantly reduce clinical response. And it's not recommended, according to the label, to do any dose adjustments except when you have concomitant medications that have drug interactions or liver disease. But I do know that because of a lot of side effects that seem like they're dose or concentration dependent, a lot of people are doing that. And so I think that may be a management strategy that we can utilize if we know more about it. So concentrations in the blood is one straightforward way in which we can assess for these, lesser clinical outcomes, but not everybody has access to that. And so the other part that I work on is pharmacogenomics. So I have a lot of research in pharmacogenomics therapy, and so we wanted to see if maybe we could use this to a priori determine who might be at risk for these higher concentrations versus lower concentrations. And I have a conceptual model here that helps you understand what we did and why. So of course we talked about the drug selection and dose. The patient takes the medication, and then we have specific characteristics like I showed you before, the genetic variants and plasma concentrations, and that's going to help dictate what our clinical outcome and side effect profile is. Of course, there are lots of other things that are shown here in the slide that influence plasma concentration and clinical outcome, but because genetic variance is something that doesn't change over the lifespan, we can do it once, and it's relatively cheap now. I looked to see if there are any genetic variants that might be good targets for assessment. So elexacaftor, tezacaftor, and abacaftor, which are listed there on the slide by their abbreviations, are all metabolized by the cytochrome P450 family of CYP3A, primarily by CYP3A4, but CYP3A5 also has a significant role, as you can see here from the original metabolism studies that were done. And so it seemed that CYP3A5 was a potential good target because it is the only one of the family that has really highly evidenced variants already known, the variants that are known for clinical implementation specifically, and it also should be a drug agnostic effect for these variants because it actually renders the patient without a functional CYP3A5. And so we decided to do a variant target approach to start, and I have that data for you today. So we looked at the series of variants, 3 variants, which are denoted by star connotations, and I don't have time to go into that. If you have questions, ask me after. But these star designations do help you to sort of categorize people and whether they are able to metabolize a drug, which would be an intermediate or normal metabolizer, versus whether they shouldn't be able to metabolize a drug, which is a poor metabolizer. And that's specific to CYP3A5 specifically. And you can see the check PK in the far left of the graph in comparison to with other biogeographical groups that are defined by the Clinical Pharmacogenomics Implementation Consortium. And this is really just provided for context. So what we found here is that we actually have about 30% of people who were actually intermediate metabolizer, meaning that they have a functional CYP3A5, so they would be able to metabolize this drug with this enzyme. And this is actually in contrast with most studies in CF, where the vast majority of people are actually poor metabolizers. And so this was a very interesting finding because this means that they are much more genetically diverse than some of our other populations, and particularly important for recruitment into like clinical trials, which tend to be more homogeneous. And so the next thing that we did was we looked at the metabolizer status versus whether they had functional protein or not, and looked at the concentrations. And we really do not see a difference in concentrations between intermediate and poor metabolizers. Now, if we do have a normal metabolizer that someone is able to have two functional genes that produce a functional CYP3A5, we might see a difference. We just didn't have any in this sample. And then we also looked at sweat chloride, and we do not see differences in sweat chloride or lung function at the time of a visit, so at the steady state. We also saw similar findings for sweat chloride changes, so the absolute change from the baseline that was pre-treatment to the time of the visit. So we really don't see a difference with these particular variants, meaning that I probably picked my variants incorrectly. So in summary, check PK does provide evidence that most people with CF can maintain concentrations expected to elicit a robust clinical response. So I get a lot of questions that perhaps people who aren't responding maybe have really low concentrations, and that seems really unlikely based on this data as well as other data that we've done. But a future direction is to evaluate the effects of dose reduction to see if people who have potential concentration-dependent side effects, it may actually benefit, because as you can see, if you start at a really high place and you have side effects that may be concentration-dependent, you lower the dose, you're probably still going to be in a range that's going to elicit a robust clinical response, and I know a lot of people are doing that and have seen that. Sweat chloride level is correlated with the steady-state plasma concentrations we're seeing in this study, but the estimates I showed you today are preliminary, and we're going to do much more robust population pharmacokinetics that will provide better estimates and more robust conclusions in the near future. And some patients may have variable concentrations because of different metabolism transport, but it's unlikely to be related to the CYP3A5 activity. However, CYP3A4, CYP3A7, P-glycoprotein, and other transporters are involved in the metabolism and transport of all three of these compounds, and we're planning a gene-center association study to evaluate for novel and known variants that may be influential. So I just wanted to take a moment to acknowledge the volunteers and their families who make this work possible, and as well as the CHECK leadership team, the CHECK PK team, and the UAB Cystic Fibrosis Research Center and Statistical Support Program. My funding is also listed on this slide, and I'm happy to take any questions.
Thank you, Jennifer. Wonderful presentation. You've put a lot of work into that, and I think it's helping us to answer this big question that we have, which is, what do we do for our patients that we're reducing doses on, right? So in your opinion, do you think there is a spot for this testing, like even getting drug levels in patients who are reducing doses on?
Yeah. So, I mean, currently the manufacturer label does not recommend therapeutic drug monitoring for modulators, and I think that's in large part because, in the upper limits of these concentrations, they didn't identify a lot of adverse events, but I know also that in our real-world use, we're seeing a lot more of a signal for things like mental health issues and liver transaminase elevations, and that are necessitating dose reductions, and people are having success. And so I think that long-term, we may not need to do therapeutic drug monitoring, but we definitely need to be doing a little bit more research in this to understand where we're starting from and what the effects are of these dose reductions, and make sure that these really are concentration dependent, which I think that some of them definitely are. But we need to know that a little bit more, and so that we can do this in an evidence-based manner.
Thank you. Yeah, go ahead.
Is there any future look that we see for looking at patients that were above the upper limit? I think clearly it's just BMI, liver disease, GI disease, outside of the genetics.
Oh, yes, absolutely. We are planning that covariate analysis. So sex, race, weight, we'll have more covariates in the CFTR as well, based on lung function, things like that. So we will be doing all of that, and hopefully I'll have that next year. maybe before the conference, we'll see.
I have a question. Obviously, this is more in the investigational phase as far as being able to apply concentrations and whatnot. Many of us have, patients, maybe they have non-tubercular mycobacteria. We're trying to use these, novel agents that we're not really sure exactly how much of a drug interaction is at play or not. Is there opportunity to perhaps get levels in some of these patients when we run into those clinical situations that can, serve a couple of purposes? One, help drive clinical care to make sure we're not over-adjusting or under-adjusting a medication, but also maybe helping solve some of the pharmacogenomics or, some of your questions you have from a scientific piece.
Yeah, exactly. Plasma concentrations, they are what they are for that individual patient, regardless of all the different factors that we could possibly want to study. Yes, I actually have an ongoing study called Modulation Variations in Cystic Fibrosis, which is open for enrollment for remote recruitment. It requires a minimum of single sample. We can receive samples from any institution. It's currently unfunded, so I do have a limit to how many I can do. But I'm hoping that as people contact me and are able to set up the sending of the samples, which I try every few months to make easier so that people can do it more effectively, yes, we can do that.
Yes.
So just contact me.
Yeah.
I would really like to be able to offer it as a service. One of the differences between our service is it's a research tool, but it is fully validated to FDA standards, and we would be able to submit it anywhere that we needed to if we had interesting findings that might prompt changing of the label.
Great. Any other questions?
Yes.
We see some patients who have mental health side effects with catheter, do you see any correlation with levels? Because we've seen where we reduce the dose, they seem to go away.
I'll be honest, I am planning to do that study, but I haven't done it yet. And we definitely do see that for some patients who have, for which we have samples who had a side effect such as mental health issues and have had resolution, that their concentrations are lower than what we might expect based on standard dosing, but most of the time they're still within the range. Sometimes they're not, but most times they are still within the range that we'd expect for a good clinical response. But that is a study that really needs to be done because I do know that at least some of these compounds cross the blood-brain barrier and are definitely causing some neuropsychological effects, and I really think maybe concentration dependent.
And kind of going based on that, did you find that any of the patients that you studied, did any of them make dose adjustments based on the findings that you got?
You mean for the check
Yes,
study?
yes.
No. Well, these results for this study are not returned to the patient.
Oh, okay.
But the modulator variation study that I have, where I would see that and actually all of my other studies, I do have IRP approval to be able to return it all to the providers and the patient so that we can assess.
Okay.
I can't make dose adjustment recommendations specifically because it's not, evidence-based, but we can let you know where people are.
Yes, great.
So, thank you.
Well, thank you so much. All right, and then our last speaker, if you want to come up. For Yaling. Yes.
This button is not work. It still work as well. Okay. Hi. Good morning, everybody. My name is Xingsen. I'm the co-host, the author with the Mr. Yi. So I will present today on behalf of the Mr. Yi. And the presentation, title is the Rapid Health Decline in CFTR GBI1 defect after discontinuation of the CFTR modulator. For many years now, we using ferret model, we studied CF pathology and evaluate therapeutic method, including the CFTR modulator. So I really feel honored to have an opportunity to come this group to present our findings, which really relevant to the clinical practice. Especially, I'm not a PharmD, so I'm just research. So, okay, work. It doesn't work. Oh, I see. So we have known that with the therapeutic method development, especially the introduced CFTR modulator, the lifespan of people with CF have the survival rate and dramatically increased. So there are many, so it's not surprising that many men and women want parenthood. So from the left figure, we can see in the 2009, there are about 300 people reported is pregnant, but only 1 year after, about 2020, the number is almost doubled, about 600. Less is great, the number is great, but for the clinical perspective, I think they have some concerns about the therapy. Because the CFTR modulator is, I think, usually called chronic maintenance therapy. In clinical trial, as a rule, they will think about the whole life usage, whether during the pregnancy or before and after pregnancy, they should continue use or discontinued. So in this presentation, we try to answer the 3 questions. The first one is consistent use the CFTR the whole life, you include the pregnancy and the lactation. And the second question, I trying to answer the questions whether follow the clinical suggestion and at a certain date or pregnancy after pregnancy, we stopped W16 or the CFTR modulator. The third question is we want to answer the concerns whether before pregnancy they have experienced some time discontinued W16 CFTR modulator, then pregnant, what effect is after pregnant or lactation. Allow me to introduce a little why we use the ferret models, because compare the current models, different models, ferret, pig, and rat rodent, different from the rodents, CF ferret mimic faithfully almost all the phenotype observed in human with CF, so including the lung problem, in intestine, and especially the pancreas disease is this disease not have the phenotype in rodent models. So I think ferret is a very ideal model to study the not a pulmonary disease, or also the extrapulmonary, the organ effectors. Oh, sorry. This is where our previous study, we used the ferret as model. We give the CFTR modulator at the pregnant period. We start giving the avicaptor at the E28 days, about 2/3 gestation in ferret. We found the modulator present can cross the placental barrier and into the fetus. But when we examine after birth, we examine the organ effect, we do see this during pregnancy give the W16 or avicaptor, they have the beneficial effect. They rescue the development disease, including the intestine disease, meconidium, and the pancreas, exon pancreas insufficiency, and reproductive defects. So they can rescue even during the pregnancy give the CFTR modulator. This is the in short summary. So VSMT given the pregnancy, give the VSMT can rescue the development disease, and after born and give sustained CFTR modulator can increase the exocrine pancreas function, include the endocrine glucose intolerance, and can sustain the growth, survival rate, and reduce the lung disease phenotype. Recently, we do another studies, mostly focused on the lactation stage. We give the whole life the ferret, or either male and female give the VSMT treatment, even during the pregnancy. After birth, we monitor the CFTR modulator, present the milk and blood, and want to determine the relationship. We found during lactation, when we compare the concentration CFTR modulator, the milk and the blood in gel, even the concentration lower, like really present in the milk. And when we check the concentration in the kit, we find the lower concentration CFTR modulator in the milk. They can still reach in the kit can still reach some levels almost similar with the blood. So even you after give the dosing the kit, they still but they can increase the concentration in kit. The milk dose is still can go to the fetus during lactation. Even the concentration very low in the milk, but this kit really can reach the effective dose during lactation. This one we examined the pancreas insufficiency. We found about 70% kit maintain the sufficiency, so it's different from KO. That means the lower concentration CFTR modulator in the milk, they can still work on the kid, that will have effect. But it looks like the benefits of effect now we see, if we see the pancreas sufficient point of view. So the first question is, it looked like this is animal study, but recently have the case report and evidence increasing that even the human woman pregnant during the pregnancy, they continue use the VSM70 or the CFTR modulator, still look like no or the worst effect in kid and look like had a beneficial effect. So this is the conclusion. But what about discontinue if we follow the clinical the rules? So we stop after lactation or during pregnancy. So that's why I want to answer the second questions. This is the experiment design. We still use the helicopter response ferret models, G5-1D ferret, and we before birth we give the in utero treatment to rescue the development disease, and after birth we have this ferret divide two groups. One group is whole life on VSM70, another group maintain about 1 month, then removed VSM70 as the discontinued group. We want to check what's the effect after stopped VSM70. The effect we examined is pulmonary effect, but mostly we focus on the histopathology. We did not show the functional test yet. So now we mostly focus on the extrapulmonary effect, including the liver, intestine, and the pancreas. Pancreas will also examine the exocrine pancreas, endocrine pancreas, and mostly focus on the ELITIS 1, whether they have the pancreas sufficiency or insufficiency, whether they have affect the body weight and glucose, the endocrine effect. The first striking observation is that we found after remove the CFTR modulator, we found they have two-phase mortality. They call it mortality. The first happened very rapidly, about 3 weeks after removed VSMT. they lost about 20% kid. This mostly caused by the intestinal obstruction or the rectangle prolapse. Second phase happened about 6 days after, and they lost about 35% the kid. The reason we examined his pathology, we found most obvious changes is the intestinal inflammation and aberrant liver function. So we think maybe the mortality second phase is related to the associated with these abnormalities. Yeah. So this slide shows his pathology in the lung. The second phase or include the first phase like that. We did not see the overt his pathology change in the lung. But we do see the lung function, even we did not show here after remove the CFTR modulator, the forced expiration volume, in fact, is 0.4 is effect, and also the mucous ciliary clearance is have effect. But his pathology looks like is normal now. And another obvious changes is the intestine inflammation. Almost all the cases they have the moderate to severe intestinal inflammation. From the figure here, you can see in the on VS70, this is the control, this is on the CFTR modulator. The intestine crab is even not as clear as the wild type, but listen severe in the off VS70, the intestine, the crab, they have a lot of the insulator, the material in there, mucus-like. Sometimes we can see the inflammatory cell in there. And the liver look like it's similar as the lung, no or his pathology change, but the function on the dead ferret, the mortality ferret, they have a higher level ALT, the changes off VS70, but not mortality one. They still have normal ALT, so we think maybe they have some relevance to the lung liver function. They have that. And this is most obvious change is the pancreas. From the microscope, you can see the lung is normal lung in the A, and the B is the off one. Even about 3 weeks or 4 weeks, we can see the fibrosis morphology change, and the on almost similar as the wild type. And his pathology see that in the off group ferret, the pancreas developed in the typical CF features. They have lost almost all the axon green acina and the dark dilate and filled with the mucus in the lumen. And on pancreas, almost all, I think 90% is normal, but just some small focal is abnormal. And the bottom histology is we see the fibrosis staining in the off-growth pancreas, severely fibrosis. And it's the histology change. And we also examined the glucose response after remove the VS70. We do the oral glucose tolerance test. We found after remove the VS70 CF monitor, they developed postgranule glucose hyperglycemia. So this is the typical features in the CF patients. In summarize, and the withdrawal VS70 early in life lead to rapid decline in the intestine and pancreatic and hepatic functions. All these effects, especially in intestinal inflammation and the lung liver function, may contribute to the increased mortality after the removal VS70. Pancreatic and hepatic function tests may be useful in monitoring the health CF infant born on but removed from the VS70 after birth. The third question is we try to answer what outcome the effect would be a pregnant woman before they're pregnant, they have the experience discontinue the CFTR modulator treatment, whatever the reasons. So this is the experiment design. We use the same method, the G/1 effect. We divide two groups. One is whole life on VS-770. The another group is discontinued at about 3 and 4 months age. Then wait for the ferret to mature at 6 months, then breed them, and then go back on the VS-770 to keep the ferret healthy. So this is the first response as you see in young ferret early life withdrawal. In the later life, we still see within the 2 months, the pancreas remodeling at the CF1, reestablished the CF pancreas disease, and the pancreas develop exon 20 insufficiency. So you can see here, the left graph, after 10 weeks, almost 0. So that means the pancreas totally trashed. When we check the conception rate and fertility and the litter size, look like the ferret experienced discontinued therapy, CFTR therapy, they can decrease the fertility significantly. So they like similar to the human report. They have fertility in the PS ferret, the pancreas exon insufficient ferret one. Maybe the relative nutrition and hormones, something. Yeah. The litter size is also decreased, but the decreased reason is because of another disease. We found this one is we have about 7 the discontinued growth ferret, 7 examined animals. They have 4 of them developed acute fatty liver in pregnancy, and in normal one, 14, only 1 have the such disease. So in the picture A, so the fatty liver disease, they all cross all the kids. They have the yellow liver. And his pathology, so steatosis, they have fatty into the liver. So this C and D is about the gallbladder. They have a lot of the inflammatory cell infusion around the gallbladder, the bile duct, and the bile duct filled with the mucus around there. So in summary, the dramatic steatosis likely due to the nutritional demand or defect in fatty acid oxidation, and correlated with large litters, because we found they have the ALFT, the ferret, they have the larger litters, more than 6, but only one is have 1 or 2 liters, they did not develop disease. I think more litters, they have more nutritional demand, so they can cause the disease. And the acute fatty liver in pregnancy in human, in normal growth population is rare, not many, but there's no report in CF population yet. So I think with the increased number of pregnancy, this one clinical may be important for the monitoring this problem, the complication. So and in that knowledge, I will thanks our ferret research group, all the staff involved in this study. Especially the John and who is the director, the National Research Center, and the supervisor is really very thanks, John. Okay, that's what I thought. I'm done.
Wow, incredible results. That was amazing.
Thank you.
Yes. What questions do we have? Can you explain how you took the ferrets off of the study drug? Did you stop them just abruptly, or was there a taper off?
Yeah, most days abruptly.
Abruptly?
Yeah, not many. No. Yeah.
Okay,
Yeah.
okay.
I'm sorry.
I'll just repeat the question because I think
Yes.
I heard. In the ferrets who developed the fatty liver disease off the VX770, did you try reintroducing the VX770 to see if the fatty liver would improve or resolve?
No, because this happened very rapidly. So the only happened about 1 week before give birth. So it's emergency one. So mostly we have to euthanize the ferret for the human point of view. Yeah. No.
Any other questions? All right, thank you so much.
Thank you.
So we do have a few minutes if people want to stick around. If we could have the speakers come up here to the podium, and if you guys have any questions, we'd love to take them at this time. And people might just come up individually. It's okay, we can all just hang out. That was awesome. Thank you all for coming, and we'll be up here to take questions if you have any.